And I wondered if I may indulge asking maybe the other panelists as well. How can you differentiate between choroideremia and gyrate atrophy in the early stages, both structurally and functionally? If you have a... Well, because we often see very end stage choroideremia pictures, I think, as Isabel, you very beautifully showed. And I say this because recently we just had a wee lad who we saw, who had most, you could almost see a scalloping in the fundus autofluorescence. And I was just curious of how you might distinguish the two. So I'd be very grateful for your opinions.
I don't know, maybe Bart also can discuss on that. Obviously, if it's a girl, you know, because choroideremia is X-linked. So, but the few gyrate atrophy that I have seen, they usually have high myopia. They usually tend to have phoboschisis and early onset cataract. And I do think they have some more pigment migration than in choroideremia. So I think the atrophy is a bit distinct than what you see in choroideremia. But maybe Bart, you have more experience than me on that.
I agree, and then the lesions in gyrate may be just a touch more peripheral, and then moving concentrically towards the center, where choroideremia shows abnormalities in the general fundus, also in the area around the posterior pole. That's something you won't see necessarily in all cases with gyrate, although I've seen cases with gyrate atrophy with a Pac-Man-like. I know that dates me, but a Pac-Man-like atrophy.
All right, we understand.
I'm sure the younger people online won't understand what Pac-Man is, but look it up. I mean, it'll be in the historic books, and some sort of an atrophy of the center can be seen.
I have another suggestion as well. Examine the mother.
By all means.
Because the mother of the choroideremia child will almost certainly have an abnormal fundus, often a salt and pepper type. If you do autofluorescence, you may see radial changes, which are quite characteristic. So examine.
Although it doesn't, I fully agree, Graham, and sorry to jump in there in the interest of time. I have had it twice that a choroideremia patient, when I looked at, eventually proven through molecular screening, had choroideremia due to a novel mutation, and so the mother was normal. So a normal mother's fundus doesn't exclude it, but an abnormal does obviously help.
Yep. Sure. De novo, yeah. Or you examine the daughter if there's one daughter.
Yeah.
Well, thank you, everyone. Could I? Do we have time for one more that I could pick your brains whilst here? Because the foveal hyperfundus autofluorescence, the little white dots that you can get early on, we're seeing a little bit more frequently in ciliopathies as well as achromatopsia. I was wondering, is it foveal cone redundancy that allows you to have these cones under stress, but no functional consequence? I wondered if you had any views or ideas about that.
You mean hyperautofluorescence? Is that what?
Yes, where you have a white dot hyperfundus autofluorescence right at the fovea.
In the achromatopsia patients. In the
achromatopsia patients, but we've also seen it in some ciliopathies and also like CLN2, for example. Yet it doesn't appear yet to have an identifiable, there's no widespread cone dystrophy. There's no maculopathy that you can actually detect functionally. I was just curious as to why this can herald something or what it might mean.
It might just be the sign that you can see prior to atrophy of the central area at the level of outer retina, being the loss of the central cones, which in quite a number of cases of achromatopsia you can see later on. And so the interesting thing is that if you look at dog models of achromatopsia, they seem to have a cone, functional cone response very early on in life, immediately postnatally. Some of the dogs described with eventually achromatopsia, 2 mutations in CNGB3 or A3, you see a cone response, and then it immediately dies off in the weeks after. And so this has made me think, and this is really left field thinking. Don't take this as certain. It's my interpretation. Could achromatopsia be like a very early cone dysfunction that initially after birth has some function remaining and then it crashes? Whether the hyperautofluorescence signal in the central fovea indicates a predecessor of what is eventually what you can see on OCT in some of the patients, being an absence of the photoreceptors or at least a paucity of thereof. I would assume that, but I'd love to have Isabel's input.
I'm not
sorry.
sure that we actually have time for that, I'm sorry, because I think according to the timing that we've come to the end. But
we've come to the end already a couple of times, I think 10, 14 minutes now, so we can get it, we can carry on. We can just have her answer and then
just very briefly, actually, don't forget that the outer retina is kind of masking the autofluorescence of the RPE, and it's in these defects, that you can get in some achromatopsia. It could as well be a window defect because there's no outer segments, and then you can see through the natural hyperautofluorescence. That may be some hint.
We've just been given an extra 2 minutes.
Excellent.
But it is strange to see in achromatopsia some of these people later on having no outer retina or outer retinal cells representing the cones. And the interesting bit is from the early results from the gene therapy trials is that you don't really get like spectacular results, at least. Now, obviously, there's the whole question of amblyopia and so on and so on. So that's going to go on for more than 2 minutes. So we'll stop there.
Well, if I may, I will ask you one question. Isabel, Bart, both can answer within a minute. Where do you think we're going to get the funding from for the necessary gene testing, which is going to be indicated in most inherited disease clinics? Certainly, I work in Singapore. People don't get it for nothing. It's very expensive, and it's a challenge.
Isa?
So it's very quickly, I would say we are lucky currently in France because we have 2 national platforms supported by the healthcare, but I don't know how long it will last.
I personally believe that if the world were to move to systems like the European National Health Services, that would be really a good thing. Now, I'm under no illusion that that will happen, but I do believe that if people were to pay generally as a population to add money into a pot that could pay for such screening, that would be a really, really positive thing for the population. I think it's a shame to have to pay, like in Singapore, for molecular screening using grant money. But then again, you pay less taxes. So, but if there's money for military, there should be money for genetic screening.
I don't think we should be mentioning military at the moment.
Yes. But on the other side, Graham, the technology is improving and the prices are dropping. So at some point, it may be less expensive for these genetic testing.
Yeah, but they're still very difficult to interpret the results. Okay, I think we need to wrap up now. So can I thank all the presenters very much for a splendid job, for sharing expertise, for sharing your time, and for committing yourselves to SOE. I think SOE should be pretty happy, and I hope the audience were pretty happy. There will apparently be a survey at the end of the webinar for the participants. If you could please take the time to complete this, it will be appreciated. And thank everybody for coming, and particularly nowadays with what's going on in the East, stay healthy, stay well, and be nice to everybody.
Bye-bye.
Take care.
Bye-bye.
Bye-bye.